Hello and welcome to Pace Hospital's podcast. Today, we are diving deep into a topic that is liver function test, your body's way of signaling how well your liver is doing its job. The liver is a powerhouse organ responsible for detoxifying, producing essential proteins, and maintaining overall balance. Joining us today, Dr. Govind Verma, an interventional gastroenterologist, transplant hepatologist, and endocrinologist with extensive experience in interpreting and managing liver function tests. In today's episode, he will explore the purpose of liver function tests, their key parameters, the role of bilirubin, and the potential causes of abnormal liver function. Dr. Govind Verma, thank you for joining us at Pace Hospital's High-Tech City. Let's start by understanding what are the parameters of liver function test.
Hello dear friends, I am Dr. Govind Verma, gastroenterologist and hepatologist working at Pace Hospitals. Today I would like to talk about liver function test. Now, this is the most commonest test which is being done and advised by an hepatologist or a liver specialist for a patient who comes to them with a liver problem. Now, what are the tests which are covered under the liver function test? We call it as parameters, for example. So the first is that serum bilirubin, which is total bilirubin, direct and indirect bilirubin, SGOT, SGPT, also called as AST, ALT, alkaline phosphatase, total protein, serum albumin, serum globulin, and prothrombin time. So this is a normal liver function test panel which is being done in most of the places. There are few tests which are done additionally and to be included in liver panel are Gamma-GT, we call as Gamma-glutamyl Transpeptidase, and another is, as I said before, INR and Prothrombin Time. So this is the list of parameters which is included under the heading of liver function test.
Dr. Govind Verma, what is the purpose of liver function test?
Now, why liver function tests are usually advised? This is the commonest question we all will have. So, basically, liver function test helps you in knowing what is the condition of the liver, what is the synthetic function of the liver, what is the liver damage which has caused because of the various liver disorders. It also helps you in knowing the coagulation function of the liver. It also helps you in liver synthetic function. It also helps you in knowing the liver disease per se, differential diagnosis of a liver disease. Now, how does this help a patient who has a liver disease based on the liver function test? How do we interpret it? So before I go for interpretation, I would like to first talk about basic of liver function test, that all the liver function tests are usually to be done in a fasting state, because in a patient who has had food, the interpretation of alkaline phosphatase may change, even the SGPT may falsely get elevated. So liver function tests to be done in a fasting state. This is one. Two, whenever we do liver function test, it is done with the help of blood test. So this is a blood test with which we can come to know various functions of the liver. As I told in brief, the synthetic function, coagulation function, liver function as a metabolic marker, and liver damage or differential diagnosis of liver disease we can come to know by doing this liver function.
So doctor, what is SGOT and SGPT in liver function test?
This AST and ALT basically is produced by the liver and it is an important marker of a liver disease. Now, you look at the two different marker, AST, ALT or SGOT, SGPT we call it as. SGOT is basically a liver function parameter which is elevated in the liver disorders, but it's a non-specific marker. What I mean by non-specific marker is that it can get elevated in patients who have other disorders also, like the patients who are suffering from muscle disorders, the patients who are suffering from the blood disorders. In those conditions also, the liver function marker called as SGOT can get elevated. Whereas if you look at SGPT, also known as ALT, this marker is more liver specific and it's usually elevated in patients with liver and biliary disorders. Now, if you look at the normal range for these two parameters, usually it is below 40. Even recent guidelines show SGPT more than 35 is ideal. So it all depends upon male and female So the parameters, the normal range may vary, but you can say that a normal value is below 35 to 40.
Could you explain what bilirubin is and why it's an important component of a liver function test?
Bilirubin actually is a product of RBC breakdown, where RBC, once that gets broken, then it gets converted into hemoglobin. So out of hemoglobin, the heme fraction gets converted into biliverdin, and this biliverdin then goes into the liver along with albumin and gets conjugated and form a conjugated bilirubin. So this is basically a cycle of bilirubin production which happens in the liver because of dying or breakdown of RBC after 120 days of natural life cycle of an RBC. So after 120 days period, RBC naturally break down in your body, releases hemoglobin. Hemoglobin is into two fraction, heme and globin. Heme gets divided, broken down into biliverdin, gets transported into the liver through the albumin, and then in the liver that helps, there the process of conjugation happens with the help of enzyme, and we have a conjugated bilirubin or direct bilirubin. So whenever we are seeing a liver function test, we see two fractions. One is a total bilirubin, and the second fraction is direct and indirect fraction, which actually combinedly gives you total bilirubin value. So why it is important to know bilirubin? Because there are certain disorders where the indirect bilirubin gets elevated, and there are certain disorders where direct bilirubin gets elevated. Now direct bilirubin is water soluble, so it gets excreted through the urine. So whenever you do a urine examination in a patient of jaundice, if you see a bilirubin in the urine, so that means that the conjugated bilirubin is more produced and it is getting excreted through the urine. Indirect bilirubin never gets excreted through the urine because it's water insoluble.
Dr. Govind Verma, what are the causes of high bilirubin levels?
Usually the causes of high indirect bilirubin are hemolysis, because the conjugation takes place in the liver. So after the liver or before the liver, whatever process happens are the reasons for indirect bilirubin high. So hemolysis is one of the commonest reason for indirect high bilirubin. Other reason is Gilbert syndrome or Crigler-Najjar syndrome. So these are all genetic disorders where you have a high indirect bilirubin, which is seen in patient with hemolysis or a genetic disorder. These are common in one. Whereas direct bilirubin can get elevated in the liver disorders, biliary disorders. It can also be elevated in hemolysis. But then more common is indirect bilirubin that. So direct bilirubin causes are usually liver and biliary disorders, and those are more commonly seen in patients also with hepatocellular dysfunction. It can be cirrhosis, it can be liver cancer, it can also be because of the drug induced, it can be because of overdose of the paracetamol. So there are many causes which can lead to hepatocellular damage, liver damage, and can rise to bilirubin. So by and large, we don't see patient any clinical signs if the bilirubin in the blood is less than 2.5 milligram %. So the commonest question patients and relatives ask us is that, sir, my patient doesn't have eyes yellow and still you are saying the patient has jaundice, because if the patient has bilirubin less than 2.5 but more than 1.2, which is upper limit of normal, they still will be called as jaundice, but having jaundice, but then that will not be visible into eyes and you will not be able to see a clinical sign called as icterus. So a clinically visible jaundice is when the bilirubin is more than 2.5.
So doctor, what is alkaline phosphatase in liver function test?
Alkaline phosphatase, again, it is produced by the biliary cells, and disorders of the biliary system can give rise to high alkaline phosphatase. Sometimes it is also seen that patients with hepatocellular disorders can also have a high alk-phos or alkaline phosphatase. But there are many isoenzymes of alkaline phosphatase, and these enzymes subtypes are not possible to be differentiated by doing the blood test. When do we do alkaline phosphatase? We do alkaline phosphatase when we know that the patient has a obstruction somewhere into the flow of bile duct. So any disorder like which causes the bile duct obstruction, whether it is extrinsic or intrinsic, It may be pancreatic cancer, it may be bile duct cancer, it may be bile duct stone, it may be any pathology which is periampullary cancer, it may be primary sclerosing cholangitis, it may have a liver metastasis causing bile duct obstruction. All these disorders can cause high alkaline phosphatase. There are other causes also where the alkaline phosphatase can get elevated because of hepatocellular cause, which is liver dysfunction, which can be drug induced, which can be autoimmune, which can be cirrhosis of liver, which can also be because of the paracetamol overtoxicity, which can be loss of blood supply, ischemic hepatitis, ischemic jaundice we call it as. So all these conditions also can cause alkaline phosphatase elevation. And there is one more variety we call as mixed, where the patient can have mixed pattern, where the patient may have a hepatocellular damage and a bile duct obstruction. In that case, we can get a mixed pattern where alkaline phosphatase and SGOT, SGPT may also elevate.
Can you explain what is albumin in liver function test?
If the patient has a low albumin, then it means that the liver is not synthesizing the albumin, and that gives an idea that patient's liver is failing. The most commonest cause of low albumin in a patient with liver disease is cirrhosis of liver, and other causes are there where their patient can have a loss of albumin through the gut. We call it as protein losing enteropathy. There can be a nephrotic syndrome where the albumin can be lost through the urine. So there also we can have a low albumin. One of the commonest cause of low albumin can be a sepsis, where you may have a sepsis induced capillary loss, and ultimately it leads to low albumin. So these are various causes where we can have a low albumin, and it directly indirectly speaks of liver synthetic function.
Dr. Govind Verma, could you explain what prothrombin time is and its significance in a liver function test?
One of the again most important parameter under liver function test is prothrombin time. For the want of standardization, now we consider INR, International Normalized Ratio, as a standardized way of knowing the prothrombin time test valuation. Since the prothrombin time value can change, normal values can change lab to lab, so INR is a more standardized way of knowing it. And again, it speaks of synthetic function of the liver. In patients who have obstruction of the biliary tract, or the patients who have hepatocellular dysfunction or jaundice, the prothrombin time can get prolonged. Also, there are other causes for prothrombin time prolongation, like vitamin K deficiency or patients on anticoagulants. They can also have a prolonged prothrombin time.
Doctor, can you explain what gamma-GT or gamma-glutamyl transpeptidase in a liver function test and why it's important?
What is the role for a gamma-GT? Most commonly done test once you get a high alkaline phosphatase. So gamma-GT, also known as gamma-glutamyl transpeptidase, this test is a very important test. This is done a blood test again, and this test helps you in differentiating the raised alphas from the source of origin. As I mentioned, that alkaline phosphatase can get elevated in patients with disorders of bone, in disorders of the placenta, and disorders of the biliary and hepatocellular tree. So whenever you have a high alphas, to differentiate the source of origin, gamma-glutamyl transpeptidase can be done, GGT, which can get elevated in patients with liver disease. So it's a specific marker. It gives you very clear indication that the GGT is very high, alkaline phosphatase is high, then the source of high alkaline phosphatase is because of the liver or biliary pathology and not because of bone. So if you have a patient where you see alkaline phosphate is high but gamma GT is normal, then the source is from the bone, like Pagets disease or osteoblastoma, bony destruction, you can say. If you have a patient who is pregnant and you see high alkaline phosphatase, again it can be elevated because of pregnancy, where gamma GT may be normal. Gamma GT also helps you in knowing whether the patient is having recent alcohol abuse. So all those patients who are alcoholic and developing liver damage may have a high alkaline phosphatase with gamma GT, and can also have isolated gamma-GT elevation without alkaline phosphatase elevation.
So doctor, how are liver function tests interpreted?
Usually have a pattern of elevation, pattern of abnormalities for different enzymes, and based on which, as a hepatologist, we try to interpret what exactly is the reason, underlying pathology that can be. So for example, if I take SGOT and SGPT or AST and ALT, the similar synonyms. So if the SGOT is more than SGPT more than 2 times, then we consider alcohol as a cause for a elevation of the enzyme. So in that situation, alcoholic liver disease is more likely to be a cause, whereas the reverse, if SGPT is more than SGOT, then we consider non-alcoholic steatohepatitis or simple fatty liver disease, or we can have autoimmune liver disease, drug-induced causes, ischemic causes as a possibility for an abnormal liver function test. You can also see the elevation of the enzymes also gives an idea about the possible etiologies for a liver dysfunction. So if I get a patient who has a SGPT and SGOT elevated around 4 to 5 times, I will consider non-alcoholic steatohepatitis, fatty liver disease, autoimmune liver disease, sometimes cirrhosis can be a possibility as a cause for the liver disease. You can also get elevated SGPT, SGOT in thyroid disorders, lipid profile abnormalities, dyslipidemia. All these disorders can give an elevation around 4 to 6 times on an average from the baseline. But whereas if you get a SGPT and SGOT more than 1000, then there are only few conditions where you can have. One of them is drug-induced liver damage, which can be acetaminophen or many other drugs which can cause a sudden liver damage. The other causes are ischemic hepatitis, where you can have a compromised liver blood flow and can have a very high levels of SGPT, SGOT more than 1000. You can also have a high levels of SGPT, SGOT in patient with bile duct obstruction. We call it as cholelithiasis. So all these disorders helps you all these tests helps you in differentiating the different possibilities, and that is how a hepatologist interpret. So if you have an enzyme which is between 2 to 6 fold, we have a common causes which we see on day-to-day basis. But a very high levels of SGPT, SGOT speaks of rare disorders, but they are rare disorders, but they are usually seen and diagnosed in a hospital setup. Patients usually have an associated problems when we diagnose these kind of conditions.
Can you interpret liver function test results in liver cirrhosis?
So if you look at a cirrhosis of liver, usually once the cirrhosis develops, which is irreversible liver damage, most of the patients will present with either normal or elevated SGPT, SGOT. SGOT is more than SGPT in alcoholic liver cirrhosis, but whereas in other cirrhosis it may not be, it may be vice versa. There is usually an elevation of alkaline phosphatase in patient with cirrhosis of liver. The synthetic function, if you look at in a cirrhosis of liver, albumin is usually very low, whereas prothrombin time is prolonged. So just looking at a liver function test, we can say that this patient is likely to have a cirrhosis of liver on the basis of enzymes, SGOT, SGPT, SGOT, alkaline phosphatase, total protein, albumin and prothrombin. As I mentioned just now, there can be a normal or elevated SGPT, SGOT or alkaline phosphatase, but there will be always in a cirrhotic patient low albumin and a high prothrombin time.
Dr. Govind Verma, let's talk about liver function test in the context of biliary obstruction. Could you explain how these tests help in diagnosing biliary obstruction and what specific changes we should look for in the results?
If you look at the liver function and can you make out the patient has a obstruction or not? Yes, we can. A patient who has a bile duct obstruction or a patient who has a obstruction to the biliary tree, we will have a very high levels of alkaline phosphatase. We will also have a very high levels of bilirubin, which is probably more conjugated bilirubin. You may not have a low albumin, and you will always have a possibility that there may be a elevated prothrombin time. So just look at the parameters, 5 parameters, that yes, in a patient who has a biliary obstruction, the LFT will show high bilirubin, conjugated more than unconjugated, enzymes SGPT, SGOT may not be elevated, alkaline phosphatase is usually elevated, very high, and also there will be a prolongation of prothrombin time in most of the cases. Can we diagnose a patient with hepatocellular cancer based on the liver function? Yeah, we can suspect, provided we look into the details. So most of the patients who have a liver cancer without a background of cirrhosis may not have much abnormality in the liver function except elevated alkaline phosphatase, bilirubin, or a low albumin. Sometimes we need in these group of patients an additional liver test to know, which is called as alpha-fetoprotein or D-procarboxyprothrombin, where we can know whether the liver function abnormality is because of the liver cancer or not. So if you have elevated bilirubin, elevated alphos and low albumin or prolonged PT, you may suspect, but again you need to take the help of ultrasound, CT scan, triphasic, MRI, and additional blood markers or tumor markers like alpha-fetoprotein or D-prothrombin to know basically whether the person has a liver cancer or not.
So doctor, how liver function tests are interpreted in the context of hepatocellular cancer? What specific changes in this test should we be aware of, and how do they guide diagnosis and treatment?
Can we diagnose a patient with hepatocellular cancer based on the liver function? Yeah, we can suspect, provided we look into the details. So most of the patients who have a liver cancer without a background of cirrhosis may not have much abnormality in the liver function except elevated alkaline phosphatase, bilirubin, or a low albumin. Sometimes we need in these group of patients an additional liver test to know, which is called as alpha-fetoprotein or D-procarboxyprothrombin, where we can know whether the liver function abnormality is because of the liver cancer or not. So if you have elevated bilirubin, elevated alphos and low albumin or prolonged PT, you may suspect, but again you need to take the help of ultrasound, CT scan, triphasic, MRI, and additional blood markers or tumor markers like alpha-fetoprotein or D-prothrombin to know basically whether the person has a liver cancer or not.
Could you explain how liver function tests are interpreted in patients with non-alcoholic steatohepatitis? What key factors do doctors look for, and how do these tests guide the management of the condition?
Now we know there is an epidemic going on in our country, obesity, and it's linked to as well diabetes mellitus, NASH, as we call it as non-alcoholic steatohepatitis. Now it is changed to metabolic associated steatohepatitis. So basically it is now the nomenclatures are changing for the same disease because of the multiple etiologies for causing a liver swelling. We call it as steatohepatitis. So what is NASH? NASH exactly is the deposition of the fat, excessive fat, into the liver cells called as hepatocytes, because of which the liver function deteriorates and we get problems in liver synthetic function, we get problems in liver function. And how do we come to know that? So the most important marker of NASH is enzyme elevation, and that is SGPT. So if you have an elevated SGPT more than 2 times the SGOT, then it is an important marker that patient is suffering from a steatohepatitis or a significant fatty liver disease, provided the patient has no history of alcohol intake but may have associated diabetes, thyroid, dyslipidemia, obesity, and so on, which can cause metabolic associated liver disease. We call it as NASH. It's kind of NASH under the family of NASH. So what do we do with the NASH? So if you look at the 5 parameters which we were discussing, I discuss cirrhosis, I discuss liver cancer, I discuss biliary obstruction. How do you interpret based on the liver function? In a patient of NASH or a fatty liver disease, you may get elevated SGPT, SGOTs and gamma-GT, but you will not get elevation of alkaline phosphatase. You may have a normal albumin, you may have a normal prothrombin time, and you may have a normal alk-phos. So, only enzyme elevation with normal bilirubin and albumin and prothrombin time make you suspect that yes, this patient actually has some kind of NASH, provided we rule out other causes, we rule out cirrhosis and all other pathology.
Dr. Govind Verma, can you explain how liver function tests are interpreted in cases of Gilbert syndrome?
The patients who have indirect bilirubin high because of hemolysis or because of genetic disorder called as Gilbert syndrome or Crigler-Najjar, these patients have usually indirect fraction more than the direct fraction, but enzymes are usually normal. So if you do SGOT, SGPT, alkaline phosphatase, total protein albumin, they usually have a normal function. In a patient with Gilbert syndrome, it's usually a disease where you have a fluctuating bilirubin level from a normal 1.2 to 6, and it gets fluctuated because of dehydration, because of painkillers, or sometimes it can be because of fever. So you will never have a patient with Gilbert syndrome where the bilirubin is crossing more than 6. If it is crossing more than 6, we consider Crigler-Najjar as a differential diagnosis rather than Gilbert syndrome. And it's a benign cause. It's a very commonly found problem in day-to-day practice. We see many patients coming to us with the dietetic restriction, with stopping of proteins and fat and everything and so on, and then we do the test. We find that total bilirubin is high, indirect bilirubin is high, direct bilirubin is within normal range, all other parameters are normal. Ultrasound abdomen, when we do, it's completely normal, and then we do a genetic test called as UGT1A assay, which comes positive because it's a chromosomal genetic abnormality which we detect, and that is how we diagnose a Gilbert syndrome. Basically, it's a diagnosis of exclusion once we rule out other causes, but it's a benign disease. It just required to be monitored closely, and these patients, if they avoid dehydration, if they avoid painkillers, and they cannot avoid fever, but then there is a possibility that during fever the bilirubin may go elevated, but nothing to worry, it will settle down again once the fever subsides.
So doctor, what is the significance of total protein in a liver function test?
So basically, total protein is divided into different subtypes, which is serum albumin and serum globulin, and this is basically a liver synthetic function. It helps in knowing the liver synthetic function, and also it helps in knowing the liver disease. So in a patient with cirrhosis of liver, we can know whether the patient has a low albumin and total protein is also low, then there is a possibility that patient may be having a cirrhosis of liver. Whereas if the patient has a high globulin as compared to albumin, there can still be liver disease because of a different reason, which we call as autoimmune etiology. So patient with autoimmune liver disease or cirrhosis can have a high globulin as compared to albumin, and can give an idea that the patient has a liver disease because of this etiology.
Is fasting required for a liver function test?
Yes, the patients who come with the liver function test requirement, they should be fasting, because alkaline phosphatase, one of the liver parameter in liver function test, can get altered if the patient is not fasting for the blood test.
Can dehydration affect liver function test?
Yes, few patients of Gilbert syndrome, as I mentioned, those who have high chances when the patients are dehydrated, the bilirubin may get falsely elevated or can present with jaundice. So that's why we always mention that patients should have adequate hydration before giving the blood test.
Dr. Govind Verma, can you help us understand some of the common causes of abnormal liver function?
The diseases of liver, diseases of blood cell disorder, diseases of the skeletal muscle, all can cause in some or other form abnormal liver function. But to enumerate few, like we have patients who have alcohol as etiology, can cause alcoholic liver disease, whether it's a fatty liver, alcoholic hepatitis, alcoholic cirrhosis of liver can cause liver function abnormalities. Patient with infection anywhere in the body, sepsis can cause liver function abnormalities. Patient with autoimmune etiologies can affect liver as well, can cause liver function abnormalities. Patient with diabetes or thyroid disease or lipid abnormalities like triglycerides or cholesterol elevation can cause elevated enzymes like SGPT, SGOT and cause a disease called as metabolic syndrome or NASH and can cause liver function abnormalities. Patients who are on toxins or patients who are on drugs which has a hepatotoxic effect like methotrexate or azathioprine or many drugs which are liver toxic antibiotics and all can cause liver function abnormalities. Many patients who are on heart disease, arrhythmias treatment like Cardiron can cause liver function abnormalities. Patient with liver cancer can also have a liver function abnormalities. Patients who have a bile duct obstruction because of intrinsic or extrinsic cause like pancreatic cancer, chronic pancreatitis, bile duct stone or pancreatic tumors, so on, they also can cause liver function abnormalities.
How often should liver function tests be done?
Patients who have liver function abnormalities, the need to repeat the test is based on the diagnosis of a patient. So if the patient has a Gilbert syndrome, I would say that I would do the test for once or twice and I will do a genetic test, fix his diagnosis by genetic and ultrasound, and I wouldn't repeat because I know it will keep fluctuating even if I do every weekly. But whereas the patient who has a cirrhosis of liver, wherein we know that before establishing the diagnosis we'll need a liver function test, and only if the liver function deteriorates then we do either once a month or once in 2 months for a follow-up to know whether the synthetic function is getting derailed, whether there is a prothrombin time is getting prolonged because of again synthetic disorder, whether the albumin is coming down or not, whether there is a raised bilirubin or not, because that gives you idea about the liver function. So in most of the cases where there is a cirrhosis, we usually repeat them once in 1 to 3 months, whereas the patients who are on treatment for steatohepatitis or fatty liver disease, we repeat only till the liver functions are again back to normal.
Can gallstones cause abnormal liver function test?
So many a times I get patients who have a gallstone disease and they come with the abdominal pain, and we start then evaluation for them. So a patient with gallstone disease can present with the abdominal pain because of gallstone itself, or can have a pain because of the gallstone slipping into the bile duct and can present with the obstructive jaundice. And we do in this group of patient liver function test, as I mentioned, wherein you can have a high bilirubin and alkaline phosphatase and sometimes elevated enzymes that makes us probable diagnosis, and then we do ultrasound and find out whether there is a stone which has slipped into the bile duct as well gallstone in the gallbladder, and that is how we diagnose that it is a gallstone which has slipped into the bile duct, and that is how it can cause an abnormal liver function test. Also gallbladder stone can compress on the bile duct called as Mirizi syndrome, can have a liver function abnormalities. Sometimes a gallbladder, when it is inflamed and cholecystitis, severe sepsis, empyema of gallbladder can also cause high alk-phos and bilirubin and can cause abnormal liver function test.
So doctor, is it possible for liver function test to appear normal even in cases of cirrhosis?
The patients who have liver cirrhosis can be divided into two types. One is early cirrhosis and the second is advanced cirrhosis. So the patients who are early cirrhosis can have absolutely normal liver function test, and when you do a liver function test you will find bilirubin normal, enzymes normal, alkaline phosphatase normal, protein, albumin, prothrombin time all normal, and all this is actually you can say that it can misguide you. A normal liver function doesn't rule out a cirrhosis of liver, but it just speaks that it may be an early cirrhosis provided you have other parameters or other tests which are showing cirrhosis of liver. So if you do an ultrasound which shows a liver ultrasound shows a coarse ecotexture of the liver, it may show a portal vein diameter increase, it may show a spleen enlargement, it may also show the liver lobules or nodularity, it may show a flow of the liver hepatopetal. In that case, that along with the other liver function tests, if you merge it with, you may be able to tell that patient may have a cirrhosis of liver. So a normal liver function doesn't rule out cirrhosis of liver, whereas in all patients of advanced cirrhosis of liver, you will have an abnormal liver function test. That is how I mean. So if you have a patient who is diagnosed for the first time in your OPD, cirrhosis of liver, based on the ultrasound, based on the endoscopic findings, it doesn't necessarily mean that he will have an abnormal liver function test, although that's most of the time seen in 70 to 80% of the patient, but again 10 to 30% of the patient in early cirrhosis may not have an abnormal liver function test, whereas in advanced cirrhosis it's vice versa. Almost 90 to 95% of the patients with advanced cirrhosis of liver will have an abnormal liver function test.
Dr. Govind Verma, one final question. Can liver function test be normal with liver cancer?
Yes. In most of the patients where the liver cancer is small in size, where the liver tissue or liver parenchyma is not much involved, we may find completely liver function, normal liver function, without any abnormalities in the bilirubin, enzymes, alkaline phosphatase or protein function. So a normal liver function doesn't exclude a liver cancer.
Thank you, Dr. Govind Verma, for sharing crucial information regarding the liver function test to our listeners. If any of you have any further questions regarding liver function test, please don't hesitate to consult a hepatologist. Remember, effective management starts with awareness and education. We will see you soon on Pace Hospital's podcast with another episode. Until next time, stay curious, stay informed, and stay healthy. Thank you.